Everyone, we are going to start next session on misdiagnosis of glaucoma. Dr. Meenakshi Dhar is chief instructor of this course, but she could not make it, and therefore me, Dr. Shalini Mohan and Dr. Reena Chaudhary are here for this course. So, would you like to say something? Go ahead. So the first talk is about history taking and detailed examination, especially not to miss secondary glaucoma, and I will be presenting it, and followed by gonioscopy. Dr. Reena Chaudhary will be throwing light on visual fields and OCT with few interesting cases. So we think and we hope that this session will be beneficial to all of you.
Unfortunately, some of the speakers, in fact, many of the speakers are not here. So the session has not all the talks being presented today. So we can make it interactive. If there are any questions, situations that you all feel we could be helpful in discussing, we'll be very happy to take that. So we will start with Dr. Shalini Mohan. Okay, go ahead.
Thank you so much. Thank you so much, Dr. Reena. And so I will be talking about pearls in history and examination. So we know we all take very detailed history and examination for our patients, but then sometimes we tend to miss something because we might be busy or something which is not in our minds. So whenever we are taking history, we do take history of brow ache or hemicranial headache. Sometimes history of frequent change of reading glasses is another important thing which we should be taking in patients of glaucoma. Now, a family history, we know that it's very, very important to take in all the patients of glaucoma. But there are certain things which we always should ask, especially steroid in any form, even if it is an ointment form which is being used. Sometimes even if patient is using some other allied medicine, maybe homeopathic or Ayurvedic medicine, which might be having steroid. Then trauma, uveitis, sleep apnea is another important factor which might be there in the patients who are progressing with glaucoma despite control of intraocular pressure. So there can be severe blood loss or any intracranial disease which might be giving us clue about secondary glaucomas. Now, another important thing which I actually wanted to highlight was use of systemic medications that may impact our glaucoma management. Now, let's see this particular female who was a 50-year-old female who was diagnosed with glaucoma 1 year ago elsewhere. So, she was doing well on one prostaglandin analog by putting at bedtime. There was no previous history of any ocular trauma or procedure. But there was past history of hypertension and she was on medication. There was no family history also. But the problem was that in recent follow-up, a visual field defect was evident in that lady, and that is why patient was referred to us, because this visual field defect appeared despite controlled intraocular pressure. So we did a detailed examination, and the vision was 6/6 in both the eyes. And this was the gonioscopic picture. We can see wide open angles in both the eyes. Central corneal thickness was normal, 543 and 539 in both the eyes. Now, when we checked intraocular pressure, it was also pretty well controlled, not that bad. Right eye was having 18 millimeters of mercury with the diurnal variation of 14 to 20 millimeters of mercury, and left eye was 16 and variation was 12 to 18 millimeters of mercury. Now, these were the disc picture. We can see the superior notch in the right eye and superior and inferior notch in the left eye with 0.8 cup disc ratio. Now, this was the visual field. Right eye almost normal, but left eye showed a inferior arcuate scotoma. So the question was that if the patient was controlled on intraocular pressure, why at all did this patient was showing this scotoma? So then we went back and we again thought, are we missing something? We examined, we asked the history of snoring, because we know that sleep apnea has been associated with progression of glaucoma. Because she was a hypertensive patient, therefore a 24-hour blood pressure monitoring was done for this particular female, and it was very noticeable that nocturnal hypotension, that is a blood pressure of almost 170/56 was seen at early in the morning around 4 a.m. So we know that nocturnal hypertension is associated with risk of glaucoma progression because of reduced diastolic perfusion pressure, and therefore we had a talk with internist of the patient, and the antihypertensive medication was adjusted so that this hypertension is not evident, and then patient did well. So the thing is that there are so many medications which patient is taking, so history of these medications is very, very important because they might actually impact the glaucoma management. Now this is a very nice study which was published in Survey, and this was glaucoma and systemic disease, and now in this it was seen that hypertension is the most common association, followed by hypercholesterolemia and diabetes, and then the cardiac disease. Now, the common medication which the patients were using were antihypertensives, followed by antiplatelets and anticoagulants, and then antihyperlipidemic agents. Now, when we are talking about blood pressure, I already talked about obstructive sleep apnea. Now, this was seen in Baltimore Eye Survey and Igna-Newmark study also, that there is an inverse relationship between diastolic perfusion pressure and progression of glaucoma. Similarly, if patient is taking antihypertensive, suppose he is on beta blocker, so oral beta blockers, they interact with topical beta blockers, so we tend to avoid giving topical beta blockers in the patients who are already using oral beta blockers. We also should understand that if patient is on thiazide diuretic or any loop diuretic, then it might lead to for the acute primary angle closure glaucoma due to anterior shift of lens iris diaphragm. So sometimes patient might present, and there are anecdotal case reports which tell that there was an attack of acute primary angle closure glaucoma. Then diuresis can be induced if there is concurrent use of carbonic anhydrase inhibitors. So especially in elderly male, we need to be careful whenever we are prescribing this drug. Now we know that peripheral calcium channel blocker are preferred in glaucoma patients, so that can be an added benefit. Now when we talk about various cardiac drugs like anticoagulants, aspirin we know is very, very commonly used these days, but it has been reported that secondary angle closure glaucoma can be due to a use of aspirin. Shall I continue? Yeah. So there was a case report of a non-ophthalmic patient which had bilateral angle closure glaucoma with warfarin. So the thing is that whenever patients are using these medication, we should be careful about secondary angle closure glaucoma which might be having in these patients. Now coming to diabetes, we know its role is not very well established because sometimes it has been found to be associated with increased incidence of glaucoma. But the neovascular glaucoma is one entity which we all should be understanding and should be careful in the patients who are having uncontrolled diabetes or having proliferative diabetic retinopathy. Now, whenever we are talking about these anti-hypoglycemic drugs, we should be careful because adrenergic agonist, which we are using, can decrease the effect of insulin and may induce hyperglycemia. So, suppose if the patient, you are prescribing some brimonidine kind of thing, then you should be careful about the effect of insulin. Then in systemic carbonic anhydrase inhibitors, if patient is using, it can lead to hypokalemia due to increased blood sugar level in diabetic patients. So you should be careful in critically ill patients. Similarly, glycerol we all know we have to avoid in diabetic patients. Now, after these systemic medication, I am coming to another case of a 22-year-old female. She was using spectacles for past 12 years and one day she had some headache and she was prescribed some medication. But then she had sudden loss of vision with headache, nausea and vomiting. This was the history she was giving. So on examination, the best corrected visual acuity was hand movement in both the eyes. She was severely photophobic, just unable to open the eyes. So when we took this girl of 22-year-old to slit lamp, this was the picture of anterior chamber depth. The anterior chamber were extremely shallow in both the eyes with circumciliary congestion. There was significant corneal edema and both the pupils were mid-dilated. Now, when we checked the intraocular pressure, it was 43 and 48 millimeters of mercury. So, obviously, this was the clear-cut case of bilateral acute angle closure glaucoma. So, we know that whenever there is bilateral acute angle closure glaucoma, it cannot be actually idiopathic generally, but it is secondary to some or other medication most of the times. So, what course of action we have to do? Again, we have to focus on retrospective history and all causes of bilateral acute angle closure glaucoma. So, in this particular girl, she took topiramate for migraine, and therefore she had this acute attack of angle closure glaucoma. So, these are various antidepressants and anticholinergic which can lead to this kind of problem. You can get this list anywhere on net or any book. So, the thing is that we have to be very, very careful whenever we are prescribing this drug. So, anterior segment imaging like UBM is diagnostic in such a scenario. We can see there is a cleft over here, and if you do ultrasound, B-scan ultrasound using water bath, you can again localize this. So, the management, obviously we have to stop the drug. We have to add systemic and oral anti-glaucoma medication, and obviously the topical medication, avoiding prostaglandin analog because this is an inflamed eye. Therefore, beta blockers, alpha agonist and carbonic anhydrase inhibitors are to be added. It is always mandatory to add topical steroid in such a scenario because of increased inflammation. Now, here we have to add cycloplegic to relax the ciliary body because there is already a effusion, ciliary body effusion, so we want to reduce that. But we don't give pilocarpine in such a scenario, and no laser iridotomy is to be done in such cases of secondary acute angle closure glaucoma. So, now coming to another few important points which we have to look in patients with secondary glaucoma. Now, whenever we are doing this comprehensive eye examination, certain things like visual acuity and refraction we all do. Now, let's go one by one to them. In visual acuity, it is very, very important to examine projection of rays, because we know that in patients of glaucoma, despite having good visual acuity, patient might be having defective projection of rays. Now, these are the few cardinal measurements which we all do in all patients of glaucoma. Applanation tonometry is the gold standard. Gonioscopy we have to do for all our glaucoma patients with dilated disc examination and of course the visual field examination. But it is important to give few extra seconds to torchlight examination. Don't forget using torchlight, because sometimes this diffuse light examination might give you some important clues. Like in this girl, you can see there is a nevus, conjunctival nevus, very classically seen in nevus of Ota. And the small baby, you can see there is a port wine stain on both the side of forehead. So, here we can see this port wine stain here and here. So, we know it is associated with Sturge-Weber syndrome. So, these kind of capillary hemangioma, if you can miss if you are directly see the patient on the slit lamp. So, do a bit of torchlight examination, and then of course, you have to see RAPD in the patients with the help of your torchlight examination. So, that is another important thing which we should not miss. Then coming to slit lamp examination, of course circumciliary congestion you all see, but sometimes in the second photograph you can see these kind of dilated episcleral vein. So we know that these type of dilated episcleral vein might be associated with raised intraocular pressure due to increase in episcleral venous pressure. So in such cases we should be careful. Now coming to another important thing which we sometimes don't do. Suppose patient is sitting on the slit lamp, don't forget to elevate the eyelid, because certain times there might be hidden clue beneath the eyelid which we tend to miss if we do not. Like a small YAG iridotomy like this might be there which is hiding beneath the eyelids, or you might be seeing a small bleb beneath the eyelids. If you don't elevate, you tend to miss. Now coming to cornea. Now it is important to examine detailed examination of cornea. Like here we can see a Krukenberg spindle indicating pigmentary glaucoma. Here you can see mutton fat KP signifying uveitic glaucoma, and here you can see tram track appearance in ophthalmic eye. Now here also you can see this is a scar which has thinned out. Now thinning of corneal scar is very much evident in the patients with viral keratouveitis, which can lead to secondary glaucoma. So you have to make note of this particular finding, and obviously you tend to check the corneal sensitivity also. The next coming to pupillary margin, which is something very, very good to give us clue about secondary glaucoma diagnosis. Like this, you might be having a pupillary ruff which is hypertrophic, or you might be having these white powdery deposits in the patients of pseudoexfoliation glaucoma, or you might be having these kind of pupillary ruff where you can see broken ruff in the cases of traumatic glaucoma, and then of course neovascularization at the pupillary margin, which is first to appear in the cases of neovascular glaucoma. Now another thing is that whenever you have a very, very busy practice and you are just unable to do gonioscopy in all the patients, this Van Herrick's test is very, very good screening modality for your glaucoma, for your patients in busy OPD. And then once you have done the ACD and you find that it is shallow, then you have to do gonioscopy for all your patients. Gonioscopy we will be discussing in detail, and then of course you have to do dilated pupillary examination and look for certain posterior synechia. Don't forget to do retroillumination, as you can see here, and then you can see these thinned out iris areas in the cases of pigmentary glaucoma. Sometimes these kind of iris atrophic patches are very, very important, and you can see it is pulling the pupil towards it, signifying previous attack of subacute angle closure glaucoma, or maybe any viral keratouveitic glaucoma. So these things we have to make sure that we don't tend to miss, despite the fact that they might be smaller subtle findings. We all know that this kind of picture, if we see, we should be careful about pseudoexfoliative glaucoma and weaker zonules. And then, of course, these are the areas where we can see the phagolytic glaucoma. Now, you can see these kind of glaucoma flecken in the cases of previous attack of acute angle closure glaucoma, or you might be seeing a washes ring like this in the cases of post-traumatic glaucoma. So then you can have a subluxated lens. So always dilate the pupil if it is indicated or angle is not shallow. Always dilate and examine the lens of the patient also. Now coming to disc examination, where disc we all know how to do, where we use any lens you are comfortable with, any 90D or 72D lens. But then of course you have to apply the correction factor to get the exact size of the disc. The intraocular pressure, we all know, applanation Goldman tonometry is a gold standard. But one thing which I actually have seen that sometimes people are using NCT, which should not be used. But in rebound tonometer is a good modality, especially in cases of scarred cornea or in pediatric glaucoma, where you can get good readings from rebound tonometer. So to summarize, I would say that we should be very careful whenever we are examining our glaucoma patients, especially secondary glaucoma and NTG patients. If glaucoma is progressing despite normal intraocular pressure, we need to look at certain things which are, we need to think out of the box, like for sleep apnea or atrial fibrillation or vasospastic disorder or hypotension. We can do 24-hour blood pressure monitoring whenever required in conjunction with a physician. Then we also need to monitor various medication which the patient is taking other than anti-glaucoma medication to avoid any systemic side effect. And then of course comprehensive examination is key to successful diagnosis. Thank you so much for your kind attention.
Thank you, Dr. Shalini. I think she's very nicely covered all the points in history taking, and I think this course actually was meant to highlight how to avoid misdiagnosis of glaucoma. So when we talk of misdiagnosis, we are talking of two things. One, we want to pick up glaucoma when there is. Second, we don't want to miss a case of glaucoma or overdiagnose it. And also we need to pick up if we are treating a patient but the patient continues to progress. And I think the role of everything from history taking to evaluation to investigations, the points that we wanted to make actually in today's session was to see how we can avoid doing that, how we can find a ideal management profile for every patient. And some patients can have glaucomatous optic neuropathy, which might be burnt out, which means that they might have had a trauma, might have had transient or few months high intraocular pressure leading to optic neuropathy, but now it is stable, might not need treatment, or a patient might have had a hypertensive uveitis episode or whatever. So it's important to know the history, not just at the time you see the patient, but also when you're following them up over time and you see that the disease is progressing despite your pressures being normal. All the important history points that Shalini Mohan brought out are very, very important. And also, as Dr. Shalini mentioned, one thing, when you see a young patient with bilateral acute rise in intraocular pressure with shallow AC, please take the history of systemic drugs that can lead to ciliary effusions like topiramate. These patients will typically tell you that their vision also started to look sudden worsening, and you will find a myopic shift very often in these patients because the lens iris diaphragm moves anteriorly. The age bracket can be variable, but very often they are women more than men at a younger age group. So I think this is a diagnosis where it is really sad if we'll end up doing PIs in these eyes. So this is an extremely vital history to take when you see a bilateral acute angle closure kind of presentation. So I think that was a very important message sent. And more we are learning that intraocular pressure is a causal risk factor, but there are so many other pressure independent factors that can lead to glaucoma and glaucoma progression, whether it is the blood supply to the optic nerve head, whether we are talking about the drug-induced issues or the systemic problems, yoga postures. So there is so much more out there, and it definitely warrants that we take our history from our patients to understand that if they've used steroids in the past, or if there's any other thing that is leading to the change that is causing constant progression despite good intraocular. And of course, compliance in history is very important. That will guide you while you're treating your patients as to how they're using the drugs or not. Maybe they're just putting it when they come to your clinic. So I think we are familiar with all these challenges in glaucoma practice, and a good history can be sometimes really, really important in our clinics. So I think very well covered. So, do you have any questions, any of you, any particular question that you have regarding this?
So I think, Madam, you brought out a very important point on yoga and posture, because so many of us are practicing yoga very regularly, and in fact it is a very good modification in lifestyle also. But sometimes few of the yoga posture, they can lead to Valsalva maneuver, where there is sudden rise in intraocular pressure. And Valsalva just does not happen only with yoga posture. It is in fact happening with many of the things, like if you are blowing some instrument, like you are playing mouth organs, or you are blowing windpipe, that can also lead to Valsalva maneuvers. And especially in patients of glaucoma, this Valsalva maneuver might lead to rise in intraocular pressure. And in fact, we have published a study also in which we did Valsalva on our patients, and there was significant rise in intraocular pressure, and also subsequently there was reduced in ocular perfusion pressure. So this leads to progression of glaucoma, and it has been reported also. So any kind of Valsalva maneuver you have to avoid. Any kind of yoga which is leading to rise in sudden intraocular pressure or rise in intracranial pressure has to be avoided in all patients of glaucoma.
So shall we move on? Do you want to cover gonioscopy?
I think you will like to move on.
Maybe I'll cover the OCT, then you do that. Let's just bring some. So I think I'll just talk about the OCT. How many of you use OCT in glaucoma diagnosis here? Quite a lot. So let's see if I can just take you through a presentation to see how OCT can help us and how we should avoid some of the common mistakes we make while diagnosing glaucoma on it, right?
Yeah.
All right. So we all understand that. Am I okay? Am I audible? Is it okay? Yeah. So Basically, we all know that in glaucoma, we are looking at structural change at the level of the optic nerve head and the retinal nerve fiber layer, which actually leads to the functional loss in the field of vision, and that remains the crux of a diagnosis of glaucoma, and also it remains a very important part of our investigation when we are trying to look for progression evaluation. So I'm going to be talking basically about how to look at these printouts and not make the mistake of diagnosing glaucoma or missing glaucoma on them just by looking at the color coding that the machine gives us. So we also understand that glaucoma is defined as basically chronic optic neuropathy, where the basic problem lies at the death of the ganglion cells, which eventually leads to the retinal nerve fiber layer loss, which of course, when you correspond to the functional loss, is the field defects that we will see in the testing. And we also know that the imaging platforms are becoming more and more popular to document the structural damage that we see in glaucoma. And over the years, OCT has replaced all the other equipments that were available in the market, like the GDX and the HRT. Now we are all primarily using OCT in our clinics to diagnose glaucoma. So I will basically be talking only on that. Even the WGA consensus series have now confirmed the use of OCT. They say that the diagnosis of glaucoma does not always require the detection of visual field defects with perimetry. It doesn't say that you don't need perimetry in all patients, but basically if there are patients who can't do it, or for whatever reason you're not able to get a good outcome, OCT can be an extremely helpful tool. And in patients who still have normal fields, there can be enough evidence based on the optic nerve head and OCT changes that will help you diagnose glaucoma and even sometimes start treatment in some subset of patients. And we will see some case examples to understand this. Imaging technologies, including OCT, provide an objective and quantitative approach to detect and monitor. And I think it's the quantitative analysis that really help us when it comes to progression evaluation in glaucoma. OCT right now currently might be the best available digital imaging instrument for detecting and tracking optic nerve structural damage. And they also said in the consensus that Rnfl thickness is most clinically helpful parameter of the ones currently available with the OCT. So GCC and all, I'll touch upon that as well. But the Rnfl thickness evaluation probably is the most important one that you would like to use in your clinics. Now, the spectral domain OCTs available in the market are very, very fast acquisition tools, which are able to take thousands of A scans in a second, and which gives you a very high resolution, almost up to 5 microns. And the important thing to remember is that in the newer tools, I particularly use Zeiss Cirrus model, but whatever tool you're using, the important thing is that these tools are identifying the optic nerve head, the boundaries for you. And it's important that you look at it, that when you look at a printout and you've seen the eye, that the detection that the system is doing is done correctly, because all the calculations are going to be based on your structural detection of where the optic nerve head lies. And that is an important training you also give your operator. And once you know, like at least in this machine, it's looking at the Brooks membrane opening as your scleral ring of the optic nerve head. And from there, it takes the center of this optic nerve head and throws a circle of 3.4 millimeter diameter around that disc. And that's where the retinal nerve fiber layer is measured. It also measures the optic cup by actually detecting the inner margins of the cup. Basically, that is where you're looking at your shortest perpendicular to the ILM. You can see how it drops that and picks it up, and then measures your rim as well for you. I will just show you, when you see a printout like this, I don't want you to jump at just looking at the circular quadrants or clock hours averages and see it's yellow or green or red, because that will always pretty much make you miss information on this sheet. What I want you to know is that what each part of a printout represents and tells you, and that is when you will not make the mistake of missing any information. So if you look at this printout, first thing to see is, of course, you're seeing the report of the same patient you're talking about. That goes without saying. Second is, look at the signal strength of your test. It's important to understand that the scan acquisition was done well and the patient's optical clarity was good enough to give you the quality of scan that will not miss anything. Second, that this particular thing, I don't know if my cursor is visible. Okay. So this particular, it's there, right? Okay. So this is your retinal thickness map. If you look at it, you have the optic disc shown over here. You can see the light gray in the center is the cup. The dark gray here, that is your neuroretinal rim. What you see, this yellow red, is your thickened RNFL. And we know when you look at a fundus, anatomically, the retinal nerve fibrillary exits at the superior inferior pole and fans out towards your superior inferior arcuate areas and goes towards the fovea. So we know that this is very typically how the retinal nerve fibrillary should be. The thicker the retinal nerve fibrillary, the brighter the colors will be: yellow, red, orange. And you can see the pattern here looks very healthy, and that's what you want to look at it. And I'll tell you how you can pick up defects here. The next map you see, this en face image, is the image when the operator is taking the scan, is also the same image he sees on the screen. And it's important to tell him, and I'll show you some pictures where how the operator can learn to acquire a good OCT scan for you. Now this will tell you the deviation from normative data. Now please remember that the normative data in these machines is limited. There are a couple of thousands of patient data ranging ages, sexes, different nationalities or geographical regions, and they take a normative data and they are comparing what your patient data is to that normative data, and according to the percentile range, making it a green, orange, yellow or red. That should not be the only criteria, because there can be normal patients who might be outside the normal range of what is in the data, or there might be abnormal patients who will fit into the normalcy. So the red, yellow, green can help you a little bit and also help you make patient understand sometimes some things, but is not the key to look at. And I'll tell you, when you look at the deviation map, what it tells you on the en face images, that all the gray thing is where there is no abnormality detected. The moment you start seeing red, yellow patches over here is the areas where the retinal nerve fiber layer is not looking as healthy as it should. Anything which is deviating from the normal pattern that the machine is used to seeing will get reflected as a red, orange point. And you'll see a lot of images thereafter which will explain that. What you have over here is basically a horizontal cross section through the optic nerve head and a vertical cross section showing you in a 2D OCT where you can see all the layers and you can understand how the volume of the cup is and whether the optic nerve had been cross-sected well at both horizontal and vertical this thing. And vertical cup disc ratio जो हम measure करते हैं, that is basically again interpolated using this particular axis. What you see thereafter is your neuroretinal rim thickness being captured. And I think that is so important, which I train all my trainees and fellows and all that work with us, that what is important to look at the disc is not the cup, it's the neuroretinal rim. Cup happens to be an outcome of the loss of the neuroretinal rim. So it is the rim that is important, and we all understand isn't as the normal topography of the rim that we see in healthy patients. And this rim thickness is being measured. If I told you right in the beginning that darker gray is your neuroretinal rim and the lighter gray is the excavation in the center. So it's measuring 360-degree rim and plotting it over this in this chart, where you have the right eye as a solid line, the dotted as the left line, and the blue, yellow or red are the normative data ranges in the general population. So it's plotting your patient, and you can pick up asymmetry here. You can pick up how well or how thick your neuroretinal rim is. This, of course, is your Rnfl, where you'll have the double hemp pattern for both the eyes. Again, solid dark line is your right and the dot is your left, and that is also mounted on the normal range that you see in the population. What you see now is, of course, the averages of the clock hours, 12, and the 4 quadrants. And the green, yellow, red is nothing, but if you see this chart, it's telling you what percentile of people will have this kind of thickness and lie in the normal range or outside it. So this is where you look at it, and some important parameters like the average retinal nerve fiber layer thickness. You'll have a lot of articles telling you 86 is the cutoff, 80. But I think more than the value as to beyond what is glaucoma or not glaucoma, it is each patient that you look at and correlate these values with what you're seeing. And we'll see a lot of examples along the way to help you make better use of these information. The next one over here is Rnfl asymmetry, which means that how different is the Rnfl in one eye from the other. And we understand in glaucoma that asymmetry can be an early diagnostic tool when it comes to picking up optic neuropathy in glaucoma. The rim area. So how brilliantly it captures the rim area of both eyes and gives it to you, and you can compare if one eye rim is thinner than the other. It also gives you the disc area. Now that is another very important thing, because there can be patients who have one disc larger than the other, hence the cup in the larger disc is also looking larger, but they could be just normal. So it's important to pay attention onto the disc area. Maybe one area disc is, let's say, 2.2, the other is 2.4. So the 2.2 disc might show you 0.5 cup and the other will show you 0.6, but both could be very healthy. Pay attention to the rim, which is what I tell when I teach the optic nerve at evaluation. It's the rim that's important. So disc size, if it's different, can also give you a cupping asymmetry, which might be healthy if your rim is healthy. It also gives you the average cup disc ratio and average vertical cup disc ratio. Cup volume is another very important parameter, and I'll show you some examples where it can help you. Not always a deep cup is abnormal, but in some cases, increasing cup volume can also be a sign of glaucoma. So here you can see it's getting flagged in red, but it might be just normally a very deep cup in a patient, because you can see how healthy the nerve fiber layer is looking over here. There is no deviation in the deviation map. The neuroretinal rim is all healthy, and so is the double humped pattern of the RNFL thickness. All your averages seem to be fitting well. Your average thickness is healthy. The symmetry is not a problem, but we can clearly see there's a mild difference in the disc size. The left eye disc is a little smaller than the right, and the rim is also hence a little thinner. Fair enough. And at the last point, you'll see a red flagged cup volume, but that could be just a physiological large deep cup, and it doesn't really mean that this patient has any glaucoma. What is a GCC scan? A GCC scan is when your operator takes the OCT and focuses now not on the optic nerve head but at the macula to measure the central macular area for GCC. GCC is basically measuring the perifoveal nerve fiber layer with the ganglion cell layer and the inner plexiform layer, collectively called the GCC. And why it is important is because we know that 50% of the all retinal ganglion cells actually do land up containing within the macular region. So it's very often helpful to pick up very typical glaucoma loss at this area, because we know that the retinal nerve fiber layer does not cross the horizontal raphe, right? So we know that the superior and the inferior fibers will always stagger along the horizontal raphe, and any kind of a loss in the GCC typical of glaucoma will show you a pattern of this nature when it is early. But of course, when it's very advanced, you're going to have losses all over. So you might not be able to see this, tortoise shell appearance of the GCC loss. If you look at this side, it's more or less a healthy GCC scan, but the moment you look at the picture next to it, you'll see that the inferior RNFL is lost, and you have that classical horizontal line dividing the unhealthy loss to the healthier one, especially in the early stages or when there is a one hemifield involvement of the loss. This is a very typical pattern of the GCC loss you'll see in glaucoma patients. Similarly, in this eye, you can see a very, very large defect inferiorly, which might be accompanied with a wedge defect in the RNFL testing as well. So you see over here, again, the thickness map, the deviation map is here, this gray en face image with very small spots. This is the area where it feels that the cells might not be as healthy as it should be. And what you have over here is the 6 segments averaged out for you, and they've also opened up the horizontal scan at the macula for you to see the quality of the scan, and if there's any artifacts and all, that also can be picked up on this particular scan. The newer softwares like Forum and all can also give you the opportunity to have a combined report where you can look at the structure and the function together. So what it can do is it can give you the RNFL thickness map along with the RNFL deviation map here. You can also see the GCC deviation map if there's any early yellow red spot or that pattern typically of the inverted tortoise shell that you can appreciate here. It gives you the averages, and it gives you the field test report where you have the grayscale, you have the total and the pattern deviation plots, and then here what you see is it merges the two. It reverses the OCT values, it inverts it and puts it over the field test for you to correlate the structural loss to the functional loss and confirm if everything is fitting in. So if I was to show you that when you see a patient where you, let's say, have a red OCT, what is important is to understand, number one, systematically when you go through each part of the OCT printout, if that red flag is fitting in at every level. So if I was to show you this scan, Oh, sorry. I'm so sorry about that. If I was to show you the scan, let's look at the retinal thickness map. We have a nice red-orange superior RNFL thickness, but what's happening to the inferior thickness? It's gone here. You can see a nice deep yellow defect, a blue colored defect, because the RNFL is washed out over here. You come to the deviation map and the system is telling you that this area is deviated significantly from the normative pattern of RNFL that the machine has been seeing in terms of the normative data. So you have a large deviation over here in the RNFL. When you pay attention to the neuroretinal rim, you will see that in the right eye, you have the inferior neuroretinal rim dipping down here compared to the left. When you come to the RNFL map, again, look at this. The right eye is dipping down inferiorly here. Can you see how the RNFL is? So the asymmetry between the two eyes is the classical change that helps you pick up this is a true glaucomatous defect. And of course, when you look at the averages of the quadrant and the clock hours, the red areas are flagging out just in the area of concern. Look at the optic nerve head. You have a classical notch inferiorly and a nice RNFL defect visible here. Even the field test is corresponding with a superior arcuate scotoma to the right eye. In the left eye, there's similar damages in the superior area. So you look at how healthy the inferior RNFL is looking. Superior is fairly good, but you classically have this defect showing up. Same thing is captured in the deviation map, telling you there the deviation is. You go back to your neuroretinal rim and RNFL, and you will be able to see that the left eye seems to be dipping down superiorly in both these scans. And there you go with the red deviation here, and you have an inferior arcuate. But if I was to tell you that if you just looked at the red, yellow, green, this little red spot doesn't look that alarming, but this patient has such a significant glaucoma with the field defect coming so close to the fovea, macula, isn't it? So the red doesn't have so much of a significance as the importance of understanding how deep the defect is, how large the defect is, and what kind of functional loss it's giving you. Let's look at this example again. A patient who's a glaucoma suspect. We can see that the left eye nerve does look quite suspicious. You can see that the inferior rim is not as healthy. And then if we go ahead and evaluate this patient further, that's his field test. And you can see some amount of borderline scattered few defects, but nothing very typical being picked up here. Although if you pay some attention in the left eye, which is the eye of concern to us really, because that nerve is the more suspicious nerve, you can see few spots superiorly looking affected. But then there are also some other spots which get neutralized when you look at the pattern deviation, but nothing alarming. You can bypass this field and say there's nothing much happening here. Let's see if the OCT can help us pick up anything in this particular case and see what we find over here. We said that the right eye RNFL is looking not too bad and the deviation is good, but look at the left eye. You have quite decent looking RNFL superiorly, but not as thick as the right eye. But inferiorly, definitely if something is happening inferiorly over here. And the deviation map is picking it as well. And to confirm more further, you look at the GCC. You have a classical inferior defect respecting the horizontal raphe. And there you go, that it is a classical inferior retinal nerve fiber loss in this patient. So even if the fields are looking okay, you might still want to choose to treat this patient if you have other risk factors, high pressures or any other angle closure or whatever. And in case you feel that no, this patient used steroids at some point, might be a washed out disease, you might want to follow this patient up. But this is a patient which is a classical glaucomatous optic neuropathy in front of your eyes, and the OCT has really helped you pick it up and confirm. You also have to understand, like all tools, OCT is also vulnerable to artifacts, which can be either patient-dependent or it can also be machine or operator-dependent. So in the patient-dependent factors, it's the pupil size. Usually the newer machines are good and they can get you a good scan in any pupil diameter above 2 to 3 millimeters. But still in very small myotic pupils, especially if there's senile meiosis or drug-induced meiosis, it's good to dilate them a little to get a good OCT scan. Dry eye definitely reduces your signal strength and can give you, when the operator is taking the scan, he can get this gray and white en-face image. He should pay attention to that, because if you have a dry eye in the patient, you'll see small yellow red spots showing up on that. And that is the time when you tell the patient to blink very often before you capture the image, or you can put teardrops to make sure the surface is not dry. Cataract, again, if it's very significant, can reduce your quality of image and the signal strength can be probably not as good. Vitreous opacity is again, and I'll show you some examples which will give you artifacts and bring out red patches on your OCT, which are non-glaucomatous. You can have epiretinal membrane at the macular area, which will make your GCC, of course, not be able to pick up a glaucoma loss. Peripapillary atrophy is an important thing to remember to look at, because sometimes when the OCT is picking up the disc margin, it takes the peripapillary atrophy as the disc margin, and hence the calculations of the neuroretinal rim and all are going to be erroneous. So that's important that clinically, when you've looked at the nerve, look at where the peripapillary atrophy is, and when you're seeing the image, you also have the on-face image on the OCT. Make sure that the machine has detected the optic nerve head borders correctly, and I'll show you a printout again to show that. Blinks and eye movements during the capture of the scan can also give you a lot of dead areas, which will flag as red. Signal strength I already mentioned. And then operator or device-induced dependent factors are basically the lens, which is right in front of the OCT machine. If it has fingerprints and other opacities or any dust or something, can also reduce the quality of your image. So it's important to make sure that time and again, not every day because you'll end up scratching it, but using a good quality lens cleaner wipes, you can have it cleaned to reduce that artifact. Incorrect axial length alignment on the OCT image. That's a very typical problem in a high myope, where you have a posterior staphyloma and all, and your machine is trying to capture here or there. You will again get erroneous reading. And of course, inaccurate optic disc margins delineations, and we'll just see an image soon. So pupil size, I already mentioned that if it is too small, you can dilate it, but otherwise, mostly you're able to capture a fairly decent OCT with undilated pupils as well. So these were the red, yellow, small, variable, flickering things that the operator can see when he's taking your OCT scan, and this is very typical of dryness, and this can diminish the signal strength and decrease the RNFL thickness that is being measured. So it's important to not miss this information, so because otherwise it will flag some false positives. So encourage the patient to blink a lot just before capturing your image to avoid these dry eye spots. Look at this vitreous floater. Now, if you look at this patient, he is glaucoma, and you're going to see, let's look at the right eye. You can see there's RNFL thickness to some extent present in the superior quadrant, but the inferior, it's all washed out. It's getting picked up on the deviation map, and all the other parameters, if you'll go stepwise manner, will confirm it. But look at the left eye. I'm not saying whether the patient has glaucoma or not, but if you look at this large black spot over here, it's a vitreous large floater, and which means that there is no data being captured behind this vitreous floater. So actually, if you look at even this scan over here, you see this dead black area, which means there was no scan done here. But the values over here will touch bang 0. Can you see how this parameters have touched right rock bottom? So this is not glaucomatous. This kind of a dead area is an artifact where you're not measuring any values. If this patient otherwise was normal, this would pick up as a RNFL loss over here, which is an artifact. So you must be able to pick it up before you analyze your OCT printout. If you look at the left eye, you have this small floater, but it's outside the 3.4 ring. So even if it's there, it's not affecting any of your measurements in this particular case, where you have an inferior wedge defect visible in the RNFL thickness map, in the deviation, and it's also represented in the change over here and here. And the artifact floater is outside the ring, not affecting your quality of scan. But the floaters, you can pick it up on the printout, and you must be able to correlate with it. These are the blink artifacts when you see these horizontal black lines, and the area where these are all black, let's say if your circle is crossing these red patches, all this is going to be a 0 measurement area. So these are going to be flagged incorrectly as abnormal. Same patient has been repeated the scan, and you can see there's still a little bit of lid artifact, but it's outside the 3.4 ring measurement where all your parameters are being calculated from, and hence at least the reliability of the scan has improved significantly. But if you pay attention, here again you have things looking not bad. The RNFL is good, the deviation is not showing you too much, but look at how the parameters are flagging over here, and very typically see the cup volume in the right eye versus left eye. So then you need to go back to the patient and understand what's going on here, and I'll show you this case again in the next few slides. This is a motion artifact. This is how your operator can see these lines, and he must make sure that the patient is not making small saccadic movements, which will again give you dead areas in the OCT, which will flag as red. So effect of signal strength on RNFL thickness, we understand that when you have low signal strength, you're going to underestimate the RNFL thickness and hence have a chances of flagging false positive. So it's ideal to get at least signal strength of 6 and more. So everything that you see red is not always glaucoma. I think I've been emphasizing on that. Let's look at this image again here. How good is the RNFL looking? Pretty good actually. You look at the deviation, there is a large patch of deviation, but where is it? It's not in the superior inferior pole. It's in the papillomacular bundles area. It's in the area which is least affected by glaucoma in the initial stages. It's the last one to go. So what is happening over here? You look at the neuroretinal rim, how healthy it is. How thick and healthy. You look at this gray circle and the cup is all fine. So this patient has all red in the temporal area. This patient has got a disease of the papillomacular bundle, whether it's a toxic amblyopia, drug-induced problem. So this patient is not glaucoma. So I think that is the important message to understand, that everything red flagged on OCT RNFL is not because of glaucoma. If you look at this particular cases, you please remember that in high myopia, when the myopia progresses, the normal anatomical configuration of the RNFL sometimes changes, which means that the RNFL doesn't fan out like this, but starts to fan out closer to the fovea. So they tend to bend more towards the fovea. And look at this nerve. This is a very small tilted nerve with an extensive peripapillary area, changes, but no cup. And you see that the RNFL is very thick, but instead of fanning out like that, it's fanning out closer to the fovea. And when that happens, the machine is going to pick up, let's say, this area as deviation. Because normally it always sees the RNFL thick here. Now it is thick here, so it's flagging the area which is thin as abnormal, but it is not abnormal. So again, correlate it with what you see on the optic nerve head. See how thick this RNFL is, but only it has shifted its position closer to the fovea, which can be seen in high myopes. Let's look at this patient now. Again, a patient who's a glaucoma suspect. You can see that the optic disc is not looking symmetric. The right eye cupping seems to be vulnerable here. We want to know if this patient is having glaucoma or not. We go ahead and investigate this patient further. This is the field test. There are some scattered points, definitely, but more or less the fields look fairly good, especially in the right eye, which is our eye of concern here. But when you look at the OCT, what do we see over here? We see a very decent superior inferior RNF, not as thick as some other patients, but it looks fairly okay. If you compare the other eye, again, the thickness is not a problem. The deviation is picking up this deviation. Why so? If you pay a little attention here, look at the vertical axis of this nerve. The nerve is attached to the globe directly, whereas in the left eye, the nerve is torted a little. The vertical dia and the horizontal dia are not perpendicular like that. It's torted. So if you go back onto the image now and look at the nerve picture, the right eye is a normal vertically oval disc, whereas the left eye is oval, but it is rotated. It's not a tilted disc, but it's a torted disc. And when the nerve, which is attaching to the globe straight, or it's torted a little, when it becomes torted, your retinal nerve fiber layer pattern will also change. So now if I was to draw a vertical axis, there it is straight, and if you make a vertical axis in a torted disc, it is like this. It's shifted by about 15-20 degrees, and hence the RNFL is also exiting the optic nerve head in that tilted manner. And because it's coming out in that 15-20 degrees away, the machine picks up a deviation here, which is not the normal that it has in the normative data. But this is not glaucoma. Right? This is just a deviation due to anatomical variation, a normal physiological anatomical variation in this patient. I hope I'm making sense and it's helpful. Okay. So this is another patient over here where you see a disc looking, this is the same patient. We've just made the functional structural map come together just for clarity. Now let's look at this patient. This is another one-eyed patient where the optic nerve head is looking very suspicious, especially inferiorly. And we do the field test. We do have some superior depression where the reliability is very low and we have a lot of scattered other points. So then what do? We do the GCC as well, and he has an ERM. Now because of the ERM, you have such a large hot area that any underlying GCC loss is going to get probably negated, and you can't really compare, and it's crossing all over the horizontal area. This is showing as thin because everything else is so thickened and elevated that relatively the other area is thinned out. But this is not picking up a glaucoma damage. You can see it's not respected any horizontal raphe, or even the pattern is not typical of glaucoma. So the GCC here is not of any help to us. So what do? Very typically when you have some amount of these field defects corresponding to the RNFL defects that are being measured over here, and if the other risk factors are positive, let's say high pressure or any other positive finding that you have, sure, this patient needs treatment. And he's one eye, so the high risk factors are very high. In a normal situation, a patient like this, you might even follow up very closely to determine whether the progression is taking place. But at all probabilities, a challenging diagnostic situation, but with so much of RNFL loss documented on OCT, this patient warrants treatment and a repeat field to confirm most probably this superior nasal defect is going to be present in this patient, and he might do a better reliable test on repeating the test. Let's look at another patient who's got a frank glaucoma. He's on treatment. Look at the left eye. You have a very large inferior neuroretinal rim thinning, which is getting flagged on the OCT thickness map. It's present in the deviation map. You also have a little bit showing up in the deviation over here, which is not being picked up clinically in the disc. And of course, it's getting flagged up in the NRR thickness, in the RNFL thickness, and in the averages. Look at the right eye, which looked quite healthy on the first glimpse. But you look at the OCT, it's all green here, all green there, and you say, okay, you look fine in the right eye. Pay attention, and the RNFL thickness is good superiorly, but inferiorly you have a nice blue defect visible, which means the RNFL is dying inferiorly in this area. The deviation map in a very subtle manner, but it picks it up. You pay attention to your maps, you'll also see a little dip in the solid line over here inferiorly, and so is it happening in the RNFL. Everything seems normal. Come back to the optic disc, you can find a very small RNFL defect present in the right eye as well. So early glaucoma has started in the right eye. The fields are still normal, but the OCT is helping you detect this early glaucoma in the right eye. So sometimes all green might still be a disease and all red might not be. That was the message that I'm trying to drive here, that when you look at the OCT scan in a systematic manner and correlate it clinically, you will not make the misdiagnosis by just looking at a green or a red image on your printout. Okay, this was just the highlight. So green disease, as I said, that normal RNFL thickness is basically a range of 95th percentile to the 5th percentile, and there can be RNFL thinning in some patients which might be present pathologically and still be a part of the normative data that I just showed you in the previous case's right eye. So it's important, but if you pay attention to the RNFL thickness and deviation maps, you will be able to pick up these early defects which will remain in the gray zone, will remain in the normative data range, but they are abnormal. And the comparison is extremely important. Look at another example. You have another patient where the right eye disc looks a little larger than the left eye. The inferior rim looks a little thinner. In fact, if you pay attention, there's a small disc hemorrhage also present at the disc. I don't know how many of you can appreciate this in the right eye. And let's look at the OCT over here. It's all green. If you look at it in one cursory way, you will say this patient has no glaucoma and you might let him go. But you go again stepwise, in a stepwise manner, like I explained. You look at the retinal RNFL thickness map and you see the inferior rim is inferior, RNFL is not so good over here. Overall also the RNFL is not so healthy in this patient, but definitely a focal loss inferiorly here being picked up on the deviation map. And you look at the NRR, again a dip over here in the right eye classically, but everything seems normal. But you have a frank optic neuropathy correlating to the disc margin hemorrhage and thinning that you picked up on evaluation. So this patient has glaucoma, right, and needs treatment, even if the fields were normal in this patient. This is a young boy with Sturge-Weber. You can see that the right eye cup looks very healthy with a lot of silver RNFL striations present. The left eye cup looks deeper, but the rim is quite healthy. Again, you can see a lot of silver striations. He basically has very high pressure only in the left eye. The right eye pressures are still all right. Classical Sturge-Weber. And if you look at the field test, they're more or less normal, some generalized depression. But he's sitting between 50s and 60s of pressure for a while, and we are struggling to control it. What does the OCT give us? What I wanted to flag out over here is, look at the RNFL is still looking not bad. Slightly less, if you look at the asymmetry here on average RNFL, yes, the left is a little thinner, but nothing significantly wrong here. The deviation picks up a small change again, yes, but pay attention to the volume. Look at what's happening to this nerve here. In younger children and younger people, the scleral rigidity is not the same as adults. They bow back under the pressure effect. That's why you have sometimes reversible cupping in the younger age groups. You have concentric cuppings because it's not the neuroretinal rim that starts to die focally, it's the lamina cribrosa that bows back under the effect of pressure, and the cup volume starts to increase. Look at how deep this cup has become because of very high pressures, and this becomes an important, again, part of the OCT that helps you pick up sometimes a change in these patients. Myopic tilted discs can be very challenging to evaluate. Clinically, the fields can have defect which are due to the myopic discs, tilted discs, and even the OCT sometimes can have lot of variations which could be because of anatomically the abnormal anatomical configurations of the discs. But the key is, if you they're difficult to comment. You can always not comment that a wedge also that you're seeing is glaucomatous or not. But if you create a baseline, it's a great tool to monitor if there is a further loss over time and to confirm. In myopes, you have all kind of problem. You can have low tension disease. You can have disc with very shallow cups and peripapillary changes not allowing you to pick up neuroretinal rim loss, notches, and RNFL is difficult to pick up because of the tessellations. So OCT can be helpful to create a baseline and follow up on that. And sometimes very typical, let's say like this wedge, very typical defects can highlight glaucoma in these eyes as well. But these are challenging eyes. Oh, this is what I wanted you to see now. Look at the left eye. It's a tiny tilted disc buried in between this large area of peripapillary atrophy. And what does the OCT do? Look at where the disc margins are being highlighted by the OCT. The disc is here. This tiny little tilted is the disc, the dark gray. But the machine has picked up the disc margin as this large area. Can you see the pink and the black line that it's taken as the disc margin? So this is important. See? This is not the disc margin. Disc margin is here, right? So when you see the scan, the right eye values are going to be absolutely not correct for you to evaluate. You see this yellow red patch over here in the scan? This is all the scleral peripapillary atrophy being visible. So again, the machine is machine. It cannot really understand a very significant peripapillary atrophy. So you have to just negate the values of the right eye. You can only pay attention onto the left eye and actually comment maybe on this particular wedge over here that must be of some clinical relevance if you look at the fields and the other parameters. So, and in the other important thing in large discs is because the 3.4 millimeter ring is stationary. If the disc is large, you're going to be measuring the RNFL closer to the disc margin. And we know that the RNFL comes out of the disc and keeps fanning out. So it's thickest near the disc margin and it starts to thin out when it goes around like that. So when your measurements are at 3.4 millimeter dia constant and your disc is large, you will have thicker RNFL measurements in normal people. So sometimes you might have an early defect in glaucoma in such eyes and it will still lie in the green zone because it is so thick. It's being measured closer to the disc margin. So remember that. So you must pay attention to the deviation maps because it will pick up there. It's picking up the deviation in terms of the pattern. So that I think is an important sector again to pay attention to. And average RNFL sector quadrant averages can again give you false. So don't look at the red, green, yellow on the averages. That's a very, very important message and very often we land up relying on that the most. Of course, in advanced cases, it is a difficult tool to depend on because you hit the floor effect and it's not very reliable to comment on the findings. So the limitations come in play. So to conclude my talk, the optic nerve imaging can be a valuable tool in detecting and monitoring early glaucoma. It needs to be interpreted with care and correlated clinically. And I've tried to showcase as much as I could as to where you should not make mistakes to miss things. The GCC definitely augments your optic nerve head imaging findings, but can be affected by macular changes. So it's not really the prime area of concern. It can be an added information to your RNFL measurements and great tool in an armamentarium to diagnose and monitor early glaucoma. The possible red and green disease has been highlighted in this presentation, and one should not take a green scan to be normal and not take all red to be abnormal till you clinically correlate and know what you're dealing with. And there will be operator and patient dependent factors that can give you artifacts, as I mentioned, like floaters and blinks and dry eye patches or lens marks. So you should pay attention to that. But another limitation of the OCT is that you're not going to pick up hemorrhages, like I showed you a picture where you have a disc hemorrhage which your naked eye can pick up by evaluating, but your OCT will not pick that up, or a pallor which will go towards non-glaucomatous damage will not be picked up by OCT. So those are the things, like even in gonioscopy, you have imaging tools, but magic of a lens being put onto the eye cannot be substituted by these machines. A clinical good examination of the optic nerve head cannot be substituted completely by the OCT. Thank you so much.
Thank you so much, Dr. Reena. That was such a wonderful presentation.
Very interesting. I just wanted to see how you time out your things, OCT, fundus image, and visual field imaging in one day, you see. Whether you do this first perimetry, you do perimetry first, you do dilating the pupil and take the fundus picture, because in your machine there is no fundus picture, OCT machine. So how do you plan out? And second question, okay, first answer.
No, go ahead.
The thing is, where you saw the visual field analysis, you saw this green and all those later. Is it normally available in the machine?
Yeah, I'll tell you that also. So number one is, how do we plan, at least in our setup, because we have a separate glaucoma wing. A patient who comes to us for the first time and he doesn't know he has glaucoma and we are detecting him as glaucoma, go through a normal comprehensive exam, which means if the patient was detected as having high pressures or shallow AC at my optometrist chamber, he gets directly referred to us. We do the gonioscopy and everything, and then we look at the optic nerve head undilated and then dilate him and see him if he's open angles. And if we feel that the patient is glaucoma, we plan investigations, which means on the day we have dilated him, if we can, we take the disc photograph and the OCT the same day and we call him back for the field test.
Dilated pupil.
With the dilated, we take the OCT and the disc photograph and we call him back for the field test. That is a fresh new patient.
How many days later?
It depends on where he lives, what suits him. It can be 1 day, it can be 1 week. And if it's just a glaucoma, which is not as acute secondary glaucoma, we don't mind those 2 days, 5 days, 1 week also. It doesn't bother me, right? But if there is a patient who has been a glaucoma patient and comes for an annual checkup, he knows the drill. He's been advised and my team knows the drill. He's come back after a year. The patient is asked if he already took the appointment for the test. He comes in, he gets the workup done, and he doesn't get AT done. No drops are instilled in the eye. He goes for the field test first. Field test is over. Then the OCT image is also taken undilated in most of my patients, because nowadays your tools are able to take good quality OCT if your cataract is not too bad and it's not a pilocarpinized pupil or a very myotic pupil. So my OCTs are done undilated, and then I see them. If required dilation, I dilate them. My fundus photographs do not happen at all visits, and my fundus images also do not happen in every patient, because my OCT, if you look at it, gives me a very good black and white disc image as well to fall back on.
Really? You don't take the fundus picture?
I take not every case. Not every case. There are some cases where, like a disc hemorrhage or, a very typical or a baseline disc image, I might do, but it's not 100%. It's not 100 because my OCT is giving me very good information about my rim, my disc size, so I don't unnecessarily weight that, and I have the en-face image on my OCT. But 60 to 70% of my patients will have one baseline disc image, one baseline. But on repeated exams, I don't do it. Only if I have a very classical new change, like he's developed a large hemorrhage or something new has happened, I might capture that. But beyond that, I don't. Because
don't you think so that OCT machine which gives the fundus image is a better option? So
it depends on what you have. It depends on what you have.
What is the standard procedure for when you take a applanation or a...
Applanation. Our NCT is more screening for the routine patients coming in. Any patient who's coming to the glaucoma department goes through AT. And any patient who's crossed over to the glaucoma department, either from other departments or on routine screening being detected for glaucoma or family history, 100% applanation, except for situations where we can't do it. Of course, tonopens and other things come into play, but 100% applanation.
So when the final decision is taken about putting the patient on the treatment modality, after everything is done, or you put the patient straight away?
It depends. If I have a patient who comes to me at 36 pressures and I have an optic neuropathy that's frank in front of my eyes and I can't do the testing that day for whatever reason, the patient doesn't have time, my scan machine is not available for him to be, then I might even start one single drug and call him back for the testing. Once I know my diagnosis is confirmed with my clinical examination and I'm capturing the data to make sure that I have the baseline to follow up on. I don't start the treatment till I establish everything. I call him back, or on the same day I do the testing. There is no hurry. Even if I start on treatment after a week, 10 days, nothing will happen because things didn't start a day before. And he's not going to turn into a blind person or an advanced glaucoma in the next few days.
People have no time today, so counseling and everything, after all these things.
I'll tell you the crux that I've learned in 22 years of my life is when you're honest to your patient and in your table time or chair time with the patient, you explain him. Of course, I do have a team of my secretaries and a fellow in my room which learns the conversation that I make with my patients. I feel, and I feel happy saying that, I feel most of our patients understand, and because we make them understand what we are doing and we don't just write the test and say get it done, and we also don't order an OCT for every patient. No. Because there are patients who have a absolutely frank large optic neuropathy, my fields are enough. Or an advanced disease, what am I going to get out of OCT? These are more early diagnoses, more challenging situations, more... so there I do a complete workup. CCT is not done in every patient. So you have to tailor it. It's not like, glaucoma, and I write 4 tests and go CCT, OCT, disc photograph, HVF, and I don't plan when you get it, go to the reception, take the time. That is not how I function. Every patient, it has to be tailor-made. I have to talk to him. I have to tell him, look, this is what you need. This is what I can offer today. Where do you stay? Can you come back tomorrow? No, I've come from Indore. I'm going back tomorrow. I said, sure. Then can you wait? Can you come back at 4 o'clock in the evening? So you have to connect and understand and also realize the emergency. If I know the patient has no time and no money, I'm going to do just a field test and do the needful I need to do with the patient where I can. So it's all tailor-made. Here I was focusing more on OCT, so you saw it in all the patients. But every patient in my clinic doesn't get an OCT. Definitely not.
Different types of disc, the PPV.
So when you look at clinically...
After the disc, the patient has come to you.
Yeah.
By the time you send the patient again for OCT, it's not done that because the technician has not taken the picture properly.
That doesn't happen in our clinic because you're constantly, because we are on the EMR and I write my remarks, he can see what I'm writing. So वो नहीं होता है हमारे यहाँ. I mean that maybe you can work around your system to make that happen. That at least your communication with your team is sorted. That mistakes will not happen. But as I said, you have to play with the patient time, patient ability to pay, your requirement of something, and a disc which is difficult for me to document on paper, I want it capture. See, there are some discs which I know, normal size, 0.7 vertical cup disc ratio, a small 1 clock hour notch inferiorly with corresponding Rnfl defect. If I write that on my file and I don't take a disc photograph, I'm not worried. But there are some discs which I want to photograph because I'll not be able to capture this and I'll miss what's happening over time. So that I play, but sure, people who can do it, that every patient a disc photograph, great, because you can pick up more than your clinical exam sometimes. Especially in, like when I train my junior people, I tell them there are at least 20 to 30% of your patients where you make an optic nerve head judgment on the paper because I teach them how I want it on the sheets and I want them to go back and take a picture and now look at the picture, look at what they've written and tell me if they're happy with what they've written. And then they show it to me to comment. So that's how I teach them. And it works out very well. They get sensitive about the fact that the optic nerve head is your window to glaucoma diagnosis. And when they're looking at that, their brain has to meditate towards the eye. They have to just look at that eye and pick up everything that the optic nerve is telling them and put it on there. And then when they take a picture, randomly they have to take 30% photographs for me to see because otherwise I can't always see all the patients. And then I look at their files and say, okay, let's discuss. What did you write and what are we seeing over here? And then sometimes I have an OCT where I can even pick up more. And then we correlate it again. So there's a lot of learning that takes place.
You report every OCT, all the aspects you report?
Yeah, so when we see an OCT, so we have a system where in our EMR, every investigation that the patient goes through is interpreted and a gist is written. Suppose I write unreliable field test, high false positive, but an inferior defect seen nasally, correlating to the optic nerve head, not correlating. That's my gist. Or let's say in OCT, I will say mild Rnfl asymmetry, no focal defect. Or I'll say inferior wedge defect in the right eye, superiorly large, superior Rnfl thinning. So I'll have a gist or a large artifact covering the area of interest to be repeated or to not be repeated. No OCT in the future because it doesn't give me enough. So things like that, because in our, let's say we have a glaucoma clinic with 7 consultants, if I don't write that, suppose I'm not there the next OPD and my colleague is seeing that patient, they will miss the entire judgment that I've made, right or wrong. At least they know the thought process that has gone into the treatment. And then they can either defer with it or agree with me, but that planning has to go. And we print it also with the patients because some of them are referred to us from outside. So they go in whenever cities, they can show it to their treating doctors. And of course, we can make errors, they can correct us, but at least you've written what you thought was happening. Yeah. About the forum. So forum is a software by Zeiss where it comes as a separate software on a system, but all your data, the beauty of forum is, suppose we have 5 field machines. Yeah. So if you have 5 machines, now the problem is every time the patient comes, you don't know which machine was he.
No, I'm saying that you get a green, and when you report the visual field analysis, it was written in green and red, etc.
That is a part of the newer software. It's
Okay, it's not available in the normal, all the VFA machines.
No, I think it's on the forum.
It's all black.
Yeah, it's on the forum. That's on the forum. But you can talk to them. Maybe they can even do it on your monitor. I don't see why not. I can ask them. But I see all my reports on the forum in my room, so maybe I haven't paid attention to whether it comes there or not. Because if you are operating different field machines and my patient one day sat on A and one day on D, then the data is in 2 different machines. How do I do a progression analysis? I mean, I do a lot of progression analysis in my presentations that I could show. So then everything is on the forum. So all their old fields and new fields are together. I have 20 years, 18 years, 15 years data to...
Yeah.
Thank
you very much.
Yeah.
It's very interesting.
Thank you. Yes, sir.
Ma'am, not all general ophthalmologists have OCT. So can someone explain a little bit how to evaluate RNFL without OCT?
Yes, absolutely. I could run
and
through
also the retinal rim. And what is the significance of cupped? Suppose the cup is 0.9. Can a patient not have glaucoma with this cup?
So I think that's a very interesting question. I do have a presentation. I don't know if the time will permit after Dr. Shalini has done the GONU. I'll be happy to run through that optic nerve head evaluation if you want to. So yes, OCT is not required in every patient. And if you don't have OCT, it's not that you can't treat glaucoma. You can very well do a good glaucoma management, just that you have to be conscientious examiner. And a large cup itself has no meaning till you do not comment on the rim. It's the rim that is of interest to us, because cup disc ratio is just the percentage of the disc area that's cupped. And what is the size of the disc? If you have a large disc, 3.2 millimeter in dia, and you have a 0.85 cup, and the rim is concentric, and the isn't is not disturbed, I'm not going to worry about anything. And the RNFL defects are not visible, nothing. What are we worried about? And the fields are normal. That's it. Let the patient go home. Maximum what you can do is do a field test to be sure. Even that might not be required if you know the rim is healthy. Right? And I can show you a lot of photographs of those patients. And immediately you look at the rim, a nice pink rim with a large cup. But the inferior, superior, nasal and temporal is your pattern, or pretty much known focal notch. No, and symmetrical, no problems. Even if it's asymmetrical, and right eye is smaller size disc, left is larger disc size, hence the right eye cup is smaller, left eye cup is larger, but the rim is healthy, no problems. No problems at all. So OCT is a helpful additional tool, but not a mandatory tool. Not a mandatory tool. You can do very good glaucoma management in your patients without OCT. Sure.
And how to evaluate RNFL?
So RNFL in some cases is difficult to evaluate, like tessellated fundus, very bad cataract, the view is limited, vitreous hemorrhage, blah, blah, other comorbidities in the retina. But in a normal patient, RNFL can be beautifully picked up if you turn the lights off. If you want to initially, don't even turn them off. Do a good 3-dimensional optic nerve evaluation on the slit lamp with a 78 or a 90D and pay attention. That's the key. Look at the disc margins, look at the rim, start following the RNFL to look for any, and I can show you umpteen number of examples in my optic nerve head evaluation where the nerve speaks to you about focal loss. In some cases, you'll not be, high myopes and all are challenging, tessellated fundus, I said, a lot of cataract, your visibility is limited. Those cases, yes, it's not always easy to pick up the RNFL defects. You look at first the normal slit lamp view and then go to the red-free filter, and that will also highlight any dark areas between the silver striations for you to pick up slit defects, wedge defects, large areas of RNFL loss. Yeah? Absolutely, absolutely. Okay, so I would say every myope, you be highly suspicious. I think that's key factor that I at least follow. The moment there's a patient who is a myope, high myope, and is above the age of 40, even a routine checkup, pay more than usual attention to them for glaucoma. Number one, very often they can have normal pressure range and develop glaucoma. Number one. Number two, they are very, very susceptible to steroid response, myopes. Number two. Number three, when you look at their discs, their morphologies are such, they have very shallow cups, they have large discs with a lot of peripapillary changes. The Rnfl is difficult to assess, becomes a challenge. So, and take family history. And these are the patients, take a disc photograph. You can be helped, as you said, sir, that, you know, if not every case, these are the cases I would do it, right? And these are the cases imaging sometimes help, and field testing if you're suspicious. But you'll have to have a higher suspicion in myopes, and also the threshold to treat them is a little higher. Central corneal thickness is another important tool in myopes. Always difficult. But progressive. See, if it is glaucoma, the peripapillary atrophy will be progressive. So disc photographs come handy. Yeah, but you know, by the time you come to an age where they develop glaucoma, mostly, I'm not talking with juvenile, by then the myopia progression is settled. So you're dealing with, if any change in peripapillary area, with the glaucomatous disease.
One of the picture you showed a line on the optic disc.
Yes.
How did you get that line?
That's on the PPT I've made for you to see the torsion, right?
Yeah.
You draw like you add a
okay.
line on a PPT.
You can show that way, all right.
Yeah. I've just tried to highlight it to the audience as to what I'm trying to say. That's all.
In one of the picture, I mean, the single strength, one was 7, the other was 4. You know, in the right end was 7, and the other was 4.
That's, I think, the young boy with Sturge Weber.
Yeah.
Because his
eye... Not before that, one case.
Yeah, so that you have to look at with extreme, what shall I say, you have to be very careful.
That was real because you were discussing all that RNFL and
this
ganglion cell, etc.
So if it's 4, you have to pay extra attention. Some of it could be erroneous. But the pattern will not change. See, a signal strength will give you generalized RNFL.
But these are images which is ultimately interpretation.
So the quality of signal strength going down will never produce a focal wedge defect. So if you have, let's say, a poor signal strength, generalized RNFL thickness measurement will be reduced a little. But if you still have what I showed you in a very systematic manner, you have, compared to the superior, the inferior half as a wedge, even if my signal strength is 4, I know this is a glaucomatous damage. But if I have the generalized little red, blue patches, I'm not going to worry about it.
It's not necessary.
Yes.
But this was very beautiful. You showed that fundus picture, perimetry, and this thing.
Yeah.
It's all.
Of course, in glaucoma, without clinical correlation, one can never reach a confirmed diagnosis.
Still go further over the angle part.
Yes.
You're good angle also.
She is talking about the gonioscopy. Yeah, I'd be happy to add anything.
Wonderful picture.
Yeah.
Wonderful.
Thank you.
OCT shows only the retinal ganglion cell loss, no other changes. And there is a paracentral scotoma. Would you treat?
Yes, of course. If I have a GCC loss, which is in the pattern of glaucoma loss, if that's what you're talking at the macular scan,
Correct.
and a central focal defect,
Correct.
but if it's horizontal, see, you can have an ARMD causing central retinal defect, which will also give you a scotoma in the center. But that's not glaucomatous. It's an ARMD or any other macular pathology.
But OCT will show that ARMD.
See, even when you do a macular OCT scan, there are different things you can evaluate in it. You can do a GCC, you can do a macular thickness scan. So if you see a GCC, you'll have to get in glaucoma a horizontal respect. Also, and I have some mimickers, glaucoma mimickers in my presentation, you can have optic disc pit mimic like glaucoma. You'll have a pit leading to an RNFL defect, classically seen in glaucoma, and presenting with a central scotoma, corresponding to that RNFL defect, in, let's say, superior pit hai, pit ke saath aapka defect aa raha hai, and disc field may be inferior scotoma close to fixation aayega. But if you pay attention to the disc, he has a pit, and it's non-progressive for 10 years. We have such patients. You know, series of optic disc pits, which were misdiagnosed as glaucoma, or retinitis. Sometimes you have viral retinitis that settles, leaving behind an RNFL defect, which will also give you a corresponding field defect. So clinical correlation will have to be done. So when you say only GCC loss and field defect, you have to see at the macula kya ho raha hai.
If the macula has a nice punched out scar or an ARMD, and you're dealing with a non-horizontal raphe respecting defect, it's not due to glaucoma.
So it's a moderate ganglion cell loss, no visual field loss. Would you treat?
So again, as I said, all these moderate early values make no difference to me till you know what you're looking at. When you say moderate, where is my loss? Is my loss generalized thinning all over, like you get in a foveal thinning? Okay, then glaucoma doesn't cause that. See, glaucoma causes death at the level of ganglion cell, which leads to Rnfl loss. And Rnfl has a pattern that it respects on the retina. Whereas when you have deeper retinal layer problems, the loss is going to be different. So moderate is just about how dense it is. But what is the topographical change and what do you see in the fundus will clinch your diagnosis.
So I think
at what level
we
of
can have
Rnfl flooring effect,
Yes.
you are alarmed, particularly in relation to management of glaucoma. Say some patient is approaching, there is a rapid Rnfl
Madam,
loss
I think we can have a
from
personalized
70,
discussion
65.
because they are requesting to conclude the session.
Okay.
The time is up.
I'll talk to you.
Yeah, you can talk to Madam personally, and we have people from next session waiting to start their session. So I think the message is loud and clear that we have to take good images of OCT. How we are taking it is equally important rather than interpreting it. And then we have to do comprehensive examination along with visual field, and then only we interpret and give our management protocols to our patient. So OCT is not just the only answer, but then we have to take everything in account, and a comprehensive examination with investigation is important to give glaucoma diagnostic. Thank you so much for all your interest in the topic, and we invite the chairperson for the next session. Thank you.
Thank you so much for your patience.